Assalamu alaikum. Good afternoon, everyone. Um, Welcome to the activity today. We have three different talks. First one by Walid Al-Thbaiti about pacemaker and defibrillator therapy in cardiac surgery. Second one would be surgery for cardiac arrhythmias by Ahmed Al-Amri. And the third one, pacemaker-related complications by Faisal Gmezi. Walid, you can share your slide and we'll start at 1:05. Do you have any consultants attending?
No, I don't have anyone.
Okay, no worries. Walid, you can start.
السلام عليكم. Good, good afternoon, everyone. كل عام وانتم بخير جميعا. This is Walid Thubaiti, Arto from King Faisal Specialist Hospital. Before we begin, I may experience some connection issue because of the area that I'm in. So if there is any issues with the presentation, please do let me know. Anyway, today we'll be talking about pacemaker use in cardiac surgery. We're going to go about some practical points with dealing with pacemaker during cardiac surgery, and we're mainly going to cover theoretical points. We're not going to delve into different surgical technique or techniques of transvenous pacemaker insertion. Anyhow, as you all know, pacemakers are a very important point in modern cardiology and cardiac surgery, in modern medicine overall, to manage different bradyarrhythmias. And they're being used to restore hemodynamics when they are lost during periods of slow heart rate. Heart pacemakers use is governed by a few principles, whether that is temporary pacemaker or permanent pacemakers. You need to have symptoms with the bradyarrhythmia to consider putting a pacemaker. You need to know the location of the conduction abnormality, and obviously you need to know the acuity and reversibility of the bradyarrhythmia to determine which form of pacing you want to utilize. The pacing, as I said, depends on the indication. Depends on the indication. It's divided into either permanent pacing or temporary pacing. In permanent pacemakers, the device is usually composed of two parts: the pulse generator and the electrodes. This is also the case for temporary pacing wires, but in different forms. So this on the right, you can see this is a permanent pacemaker, and you can see the pulse generator, which is the box, and then the lead that connects to both the device and the patient. There are a few terms that you need to know when dealing with pacemakers and terminology. Sometimes it can be confusing, especially if you take in your background physiology and even physics terms, and you try to understand pacemakers with it. Anyway, so pacing, this is the action of current delivery to the heart by the device. And the current, as you all know, is measured in amps. Because of the current that is utilized in pacemakers generally very small, so the unit that is utilized for pacing is milliamps. Sensing, this is the measurement of the produced heart voltage. The heart, when it contracts, it obviously through the SA node and the AV node, there's voltages that being recorded or sensed by the device. So that's usually sensed in the unit that is called volt. As again, just because the volt is very small in the heart, so it's measured in millivolts. Now, all of these are, it's easy to understand, but once you get into further terms such as sensitivity and capture and all of that, you start to confuse things. So sensitivity, this is the voltage level that must be exceeded to detect the R wave or B wave. It's termed sensitivity because in reality, it's a threshold. I'm showing you here some diagrams to make it easier. When the device detects an R, when it sees the voltage that it's received from the heart, you typically see R waves or B waves, depending on what you're trying to sense. For example, let's take R wave as an example. The R wave will go up to a certain limit or voltage, and then obviously will go down, and that's seen in the ECG to make it easier. Anyhow, if you put your threshold very high, the device will not, as in the first row, if you put your threshold very high,
I believe we lost Walid here on the connection. He's trying to reconnect. Let's just give him. He is still trying to reconnect. Let's give him a few more minutes, 5 more minutes. If he couldn't, maybe we should swap. The presentation is ready in case he couldn't.
Assalamu alaikum warahmatullah. I will be presenting the next lecture for time purpose until Al-Walid get in connection. So my presentation is going to be about surgical treatment of atrial fibrillation. My objectives for this presentation is to give an introduction and definition of atrial fibrillation, to give the history and evolution of surgical ablation, talk about Cox-Maze procedure, and we'll talk about guidelines and outcome. So atrial fibrillation is the most common adult arrhythmia worldwide. It's associated with increased risk of morbidity and mortality, and it has 5-fold increased risk of stroke, and it's responsible for 30% of all strokes. The pathogenesis of atrial fibrillation is associated with electrical triggers in the pulmonary veins, as well as micro re-entry phenomena in dilated area in the atrial tissues. Several established options for the treatment of atrial fibrillation already exist, but with the suboptimal result until now. So atrial fibrillation is classified into 4 categories. First category is paroxysmal atrial fibrillation, where you have atrial fibrillation that spontaneously terminate within 7 days. Persistent AFib, when you have more than 7 days, but less than a year. Long-standing persistent AFib is when it continues more than a year. Permanent atrial fibrillation is the term placed by the physician, when the treating physician and the patient comes to the agreement that no further rhythm control treatment is needed. So in 1980, Dr. James Cox first introduced surgical ablation of atrial fibrillation as the Maze-1 operation. Through ongoing investigation and optimization of this procedure, it evolved into Maze-3 procedure and became the gold standard surgical treatment for AFib. So Cox-Maze-3 procedure was done using the cut and sew technique. So as a result of that, with the advance in technology, an alternative energy source was found to be effective in replacing this cut and sew technique. And the Cox-Maze-4 procedure is a procedure that is describing the Cox-Maze-3 using alternative source of energy like radio frequency or cryothermic energy. So Cox-Maze procedure have been evoluted since 1980 after the description of Dr. James Cox about the Maze-1 procedure. They were using the cut and sew technique, and they were using different set of lesions than the current Maze procedure carry. With the better understanding of the phenomena of atrial fibrillation and the triggering point or lesions that cause atrial fibrillation, they develop different lesion set until they reach the Maze-3 procedure, which shows to be an effective in breaking all the macro re-entry circuits in the atria that is causing atrial fibrillation. And then, as I mentioned, Cox-Maze-4 procedure use the same lesions, but using different energy source. So pathophysiology of AFib and the mechanism of Maze procedure is basically related to the macro re-entry circuits in the diagram shown as the red circles and lines. And this have been described by after advanced studies of the phenomena of atrial fibrillation using electrophysiological mapping in multiple patients, finding the triggering points that cause the atrial fibrillation. So basically, you can see the lesions produced by Maze procedure in the blue lines have been described to to break all these lines of macro re-entry circuits. By this, you restore the normal sinus rhythm. So this is a diagram showing the Cox-Maze 3 procedure using the cut and sew technique. See how they used to do it. They used to cut the atrial tissue and then sew it again to produce the lesions to break these currents of AFib. But when we advanced in technology and we found an alternative energy sources, we shifted the gear toward the mainly radio frequency and cryothermia. But radio frequency and cryothermia is not the only options there, but it's most commonly used. We have the unipolar radio frequency and the bipolar radio frequency. We have the laser and we have the microwave and high intensity focused ultrasound and cryothermia. Basically, any energy that can cause an atrial injury to the tissue that can break those triggers. So radio frequency unipolar can be applied as an endo or epicardiac approach, and it heats the atrial tissue up to 90 degrees Celsius. And the bipolar radio frequency delivers the energy in between the clamped jaw, and it can heat up the tissue to 60 to 70 degrees Celsius. The main limitation of the radio frequency is the risk of injury to the coronary arteries and the valve tissue due to hyperthermia denaturation of the collagen. Cryothermia have been the trend nowadays for Maze procedure. It reduces tissue injury by forming intracellular and extracellular ice crystals formation. It's used two different gases to produce this injury, either by nitrous, which frees up the tissue up to minus 89 degrees Celsius, or the argon up to minus 187 degrees Celsius. So by this, we end up, after choosing the energy source and the lesion set, we end up with Cox-Maze 4 procedure. And Cox-Maze 4 procedure is consistent of right and left atrial lesion set. So if you look at the right atrial lesion set, the first lesion that we make is the lesion that we basically do it by the cut and sew technique, where you open the left, do your atriotomy. This is a lesion that by closing opening and closing the lesion will produce the first lesion. You connect this lesion to the SVC and IVC with two different lesions, and then you connect this lesion to the coronary sinus and then to the tricuspid valve annulus, and then to the right atrial appendage or free wall. The left atrial lesion set consists of as in the right side, the atriotomy lesion, and then you connect it to the mitral valve annulus, and you then form the box lesion, as you call it, to isolate the pulmonary veins. And then you close the left atrial appendage and connect the box lesion to the left atrial appendage line. So this is basically what the Cox-Maze procedure consists of, and it can be done, as I mentioned, in the same procedure by three different energy sources. The red line that is the line usually done by bipolar radio frequency. The blue line is the lines that only can be reached by cryothermic energy, and then the surgical incision itself can produce a lesion, as I mentioned, by the cut and sew technique. If you go to the guidelines for surgical ablation, The latest one is 2017, the European guidelines, expert consensus. And they classified the surgical indication for treating AFib into three main categories. The first category is the indication for concomitant surgical ablation with mitral valve surgery, or they say open heart surgery. And in case of symptomatic atrial fibrillation, either it's paroxysmal or persistent or long-standing, it's a class 1 to do a concomitant MACE procedure in those patients, as well as antiarrhythmic drugs. In case of closed cardiac surgery like CABG or AVR, concomitant surgical ablation is moving on to the class 2A rather than class 1 in mitral valve surgery, based on the evidence they had. At that time, the guidelines have been published. When you look at the standalone surgical ablation as a procedure by itself for symptomatic AFib with persistent atrial fibrillation and long-standing atrial fibrillation, class 2A to do standalone AFib, and for paroxysmal AFib, it's class 2B. This is according to the 2017 European expert consensus. If you move to the Society of Thoracic Surgeons 2017 guidelines for surgical treatment of AFib, also they classified it into three categories in the same manner: mitral valve operation and concomitant surgical ablation. It's class 1 level of evidence A to do surgical ablation without additional risk of operative mortality or morbidities. In aortic valve and CABG operations, it's a class 1 with level of evidence B, non-randomized. For the standalone MACE, there is three different categories: surgical ablation for atrial fibrillation patient who's symptomatic and in absence of structural heart disease, that those patients who's refractory to antiarrhythmic drugs or catheter-based therapy, it's reasonable to do standalone surgical ablation to restore sinus rhythm. Class 2A, level of evidence B, randomized trials. Surgical ablation for symptomatic persistent or long-standing persistent AFib in absence of structural heart disease. It's reasonable also to do a standalone MACE as a class 2A, level of evidence B, non-randomized. In case of surgical ablation for in the setting of left atrial enlargement more than or equal to 4.5, or if you have a more than moderate mitral regurg, it's not recommended to do only pulmonary vein isolation. You should do the full MACE procedure in order to restore sinus health. In regard of AATS examination of surgical ablation, this is done by multiple experts in surgical ablation. You can see Dr. Nate Vatz and Ralph Domeno, Dr. Vinay Badwar, all of these, and Dr. Mark Linov. All of these are experts on surgical ablation, and they examine the surgical ablation indications. And what they found in the literature, based on meta-analysis, focusing on the safety and efficacy of surgical ablation, they found that surgical ablation did not increase the post-operative morbidities. It did not. It showed improved quality of life. It showed an improved long-term survival, but not the short-term. No increase in the length of a hospital stay or ICU stay or hospital readmission. No difference with surgical ablation in regard of TIA or stroke. So we'll move on to the outcome of surgical ablation. There is multiple studies examining or showing the outcome for surgical ablation. First one done by Dr. Nevad and his group. And in this study, they examined the long-term outcome following concomitant mitral valve surgery and Cox-Maze procedure. And they found at 12 months or 1 year, the rate of sinus rhythm at 12 months was around 90% of the patients with antiarrhythmic drugs, 83% of the patients off antiarrhythmic drugs. And you can see the trend was equal around up to 2 years until the number of patients followed was significantly dropped. Could explain the drop in the number of patients in sinus rhythm. In this study, they also examined the freedom from embolic stroke in their patients' cohorts, and they found that 96.6% of the patients in their group had freedom from embolic stroke, which is a significant number. But there is no comparison between this group and there is no comparison between the group they received surgical ablation in comparison to the non-surgical ablation group. Another study, they examined the 1-year mortality and costs associated with surgical ablation for and concomitant with CABG, and they had a large number of patients who underwent CABG alone, who had the atrial fibrillation as well, and CABG plus surgical ablation in around 600 patients. They followed them around 1 year, and they found that the probability of death was significantly higher in the group who received CABG alone in comparison to the group who received CABG and surgical ablation, showing that restoring sinus rhythm did improve the patient survival without adding any significant morbidity or mortality in the group of CABG and surgical ablation. The other study is the long-term safety and efficacy of concomitant MAZE with patients without mitral valve disease. And this study was done to show that surgical ablation is not only associated with, should be not associated with only mitral valve disease, because it's the latest guidelines in 2017 was having different class of recommendation regarding mitral valve or other cardiac surgery in concomitant with MAZE. And it shows that the group who have mitral valve surgery and MAZE showed restoring sinus rhythm in 88% of the patients, while the non-mitral valve surgery showed 91% of the patients. It was not significantly statistically significant, but showed that also the non-mitral valve surgery showed an improvement or showed a good number or percentage of restoring sinus rhythm. In this study, they had, in the previous slide I mentioned, the study, we had around 711 patients of MAZE procedure, 473 with mitral valve and 238 with non-mitral valve between 2005 and 2015 or 16. They basically examined the risk of operative risk, and they found that there is similar operative risk or result in terms of stroke, reoperation for bleeding, renal failure, and pacemaker. Operative mortality was also similar, and readmission within 30 days and the length of stay. The outcomes showed similar success rate at 5 years, similar success rate or freedom from the stroke at 5 years. What they found, one of the prognostic factors or for restoring sinus rhythm was the duration of AFib. The shorter the duration of AFib, the more chance to have sinus rhythm. So the longer the AFib with the patient, the higher rate of failure for the surgical ablation, and also showed that surgeon experience played an important role in success for restoring sinus rhythm. This study shows the late outcome after Cox-Maze procedure for atrial fibrillation. And this study, they examined both the paroxysmal and non-paroxysmal AFib. It examined the previous theories where you have previous theory in the previous study where you have higher rate of sinus rhythm with the paroxysmal AFib versus non-paroxysmal long-standing AFib. In this study, it showed that 1 year, around 96% restoration of sinus rhythm in the paroxysmal group, and non-paroxysmal group around 91%. And if you keep comparing the group over the follow-up years, it shows no significant difference. So that the duration of AFib did not play an important role in this regard of this study over 5 years of follow-up. Finally, this study, they compared patients who underwent Cox-Maze procedure versus the untreated AFib. So if you compare the patient who underwent surgical ablation versus those who have untreated AFib, it shows a significant Cox-Maze procedure showed a significant overall survival rate than the untreated AFib. And if you compare the Cox-Maze procedure with the normal population without AFib, it shows no significant difference. So restoring sinus rhythm in those patients by surgical ablation showed put those patients on the normal population without AFib group, which is a very important result. Finally, as part of surgical ablation, the left atrial appendage management, this paper is concluding all the papers that's been done for the studying the left atrial appendage closure during cardiac surgery. And this paper was published in New England Journal of Medicine in 2021 about the left atrial appendage occlusion in AFib patients to prevent stroke. And they had around 4,818 patients who were adults with atrial fibrillation who had a CHA2DS2-VASc score more than or equal to 2 undergoing cardiac surgery. And they examined the ischemic stroke and non-cerebral systemic embolism during the follow-up period. And they found there's significant reduction of risk of stroke in the left atrial appendage closure group, comparing that to the patient who did not have their appendage closed. And this study concluded that closure of the left atrial appendage reduced the risk of ischemic stroke, systemic embolization, and in participants who have a history of atrial fibrillation. So as a take-home message from this presentation, I want to say that surgical ablation had the best results in restoring sinus rhythm in comparison to other modality of treatment of AFib. Surgical ablation by Cox-Maze-4 is safe, and studies showed a better survival and better quality of life versus non-treated AFib. Surgical ablation is recommended as class 1 concomitant with mitral valve surgery, and the class 2A
Dr. Ahmed, are you still with us?
Yes. Did I get disconnected?
Yes.
Which slide did I?
At the end, the take-home messages.
Yeah. Okay, I will repeat the take-home message. Then I wanted to say that surgical ablation has the best result in restoring sinus rhythm in comparison to other modalities of treatment of AFib. Surgical ablation by Cox-Maze-4 is a safe procedure, and studies showed better survival and better quality of life. Surgical ablation is recommended as class 1 in concomitant with mitral surgery and class 2 in CABG and AVR. Left atrial appendage occlusion is part of Cox-Maze-4 procedure. And if Maze was not done for some reason, the left atrial appendage should be closed during cardiac surgery. And arrhythmia surgery need experience and special training. Thank you for listening. If you have any comment or question, please. Okay, then we'll have 5 minutes break and then we'll come back for the next presentation.
Dr. Al-Walid have some technical issues. His presentation will be postponed till next week. The next presenter is Dr. Faisal Al-Gmezi. He's presenting pacemaker related complications. Dr. Faisal, you can share your slides if you want.
Assalamu alaikum. Can you see the slide?
Yes.
Assalamu alaikum. I'm Faisal Gmezi from King Fahd Medical City. My topic will talk about the pacemaker-related complication. We will start. Generally, the risk of complication exists
Faisal, can you put it in full screen?
Okay. Is it on full screen now or not? Not yet.
Not yet. Yes, now it's full.
Okay. Okay. Generally, like any invasive procedure in the hospital, in a pacemaker, the reported complication rates range from 3 to 6%. With up to 1/2 of this complication considered serious, and 4.5 require reoperation. Complication ranging from superficial bleeding to fatal infection and cardiac arrest, and also cardiac perforation. And these complications are divided in two entities: the mechanical complications and pacemaker malfunction. In the mechanical, we have the pneumothorax, hematoma, tricuspid regurgitation, infections, thrombophlebitis, myocardial perforation, lead dislodgement or break. And regarding the pacemaker malfunction, we have the failure to pace, failure to capture, inappropriate sensing, and pacemaker syndrome. Moving the first one is the pneumothorax with incidence of 1.8, and usually most of the patient is asymptomatic and discovered accidentally in the routine post-op chest X-ray. And if it's significant enough, it can cause severe respiratory distress, pleuritic pain, and cough, and all of these suggest the diagnosis. And the management, if it's greater than 10% or small pneumothorax that does not resolve, or increase in size in serial X-ray, evacuation is indicated. As we can see here in the patient post-pacemaker implantation, which developed pneumothorax, as we can see here in both pictures. Next one is the hematoma with the incidence of 0.5 to 3%. Patients on antithrombotic or anticoagulant therapy have slightly higher risk of bleeding and hematomas. The management usually is conservative with a compressive dressing or compressive device, unless it's expanded or causing a wound dehiscence or infection or skin necrosis, which need wound extirpation. As we can see here, the sign of hematoma. And here also we can see the compressive dressing and the compressive device. Next is the tricuspid regurgitation with incidence of 16%, which is considered common. And it can be direct, which is very operative, and it can be during the or in the long-term period. Damage to the tricuspid valve may occur during a pacemaker implantation from direct trauma, leaflet perforation, avulsion, or damage to subvalvular apparatus, or further interaction of the device can result in impingement of the leaflets, malcomptation, and significant regurgitation. Leaflet adhesion, fibrosis, or encapsulation can contribute to valve incompetence. And if the patients post-pacemaker implantation present with signs and symptoms of heart failure, tricuspid regurgitation should be one of the differential diagnoses. And regarding the management, the mainstay of management is aimed to volume optimization, mainly by diuretics, like furosemide, and of course, following with the cardiology. And here the picture demonstrating the perforation and the other injury of the tricuspid valve. And here is a patient before the pacemaker implantation. We can see here non-significant tricuspid regurgitation, and here post or after pacemaker implantation, we can see the lead here with the significant tricuspid regurgitation. Next, we have the infection, which can be local, like a bucket infection or a systemic infection, with incidence of 1.2%. Infection rate was lowest during the initial implantation, with the infection rate 1.5 to 3-fold higher during the revision or replacement procedures. It's okay in a form of bucket infection, in the generator, where the generator placed subcutaneously, or systemic infection like bacteremia and endocarditis, or vegetation of the leads, or both at the same time. Also, the local infection, like in the bucket infection, can lead to generator eroding through the skin. And the risk factor, like any risk factors of infection in the patient on in autoimmune disease, diabetic, end-stage renal disease, steroid use, history of previous infection, hematoma, or procedure contamination. The signs of symptoms include fever, erythema, pain, warmth, edema, brilliant discharge, or the non-healing wound. The most common organism can cause this infection is Staph aureus and coagulase negative Staphylococcus. Regarding the management, at least 2 sets of blood culture usually taken before starting the IV antibiotics. And regarding the IV antibiotic choose, we can choose the ideal is ceftriaxone and vancomycin. And also cardiology consult for the need for further evaluation by TEE and TTE to and removal and replacement of the device, and assess for vegetation. Regarding the deep infection of the lead wire or patient with endocarditis, require device removal and IV antibiotics with the 2-step approach with temporary basing for patient who is basing dependent to bridge the time between the explantation and the new device implantation. The current guideline recommend waiting 14 days after negative blood culture following device removal for valve vegetation and 72 hours for lead vegetation. And the new device should be implanted in alternative site. The recommendation of removal of the infected device is the complete device and lead removal is recommended for all patients with definitive infection as evident by valvular or lead endocarditis or sepsis. Complete device and lead removal is recommended for all patients with a bucket infection as evident by abscess formation and device erosion, skin adherence, or chronic draining sinus without clinically evident involvement of the transvenous portion of the lead systems. Or complete device and lead removal is recommended for all patients with valvular endocarditis without definitive involvement of the leads or the device. Here's the picture where we can see the generator eroding through the skin. And also here we can see the lead or the vegetations involving the leads. Now moving to the thrombophlebitis, which is the treatment usually is conservative, no treatment needed. Only we have to do Doppler ultrasound to rule out DVT. Moving to the myocardial perforation with incidence of 0.8 to 6%, associated with high mortality rate and high risk for other major complications. Perforation can lead to pericardial effusion, cardiac tamponade, pneumothorax, or even death. Risk factor include advanced age, gender, female gender, steroid use. Signs of symptoms can vary: chest pain, fatigue, fever, pleural effusion, and signs of symptoms of cardiac tamponade. And this can be diagnosed by extreme location of the lead tip in chest X-ray and new onset of right bundle branch block on the ECG. Poor basing and sensing threshold, and in this case, fluoroscopy and or CT can be helpful in localizing the tip. The management, if the patient is asymptomatic, no intervention needed. Reposition or replacement of the lead wire after the cardiology assessment. Hemo and pneumothorax may require a chest tube incision. A surgical approach is recommended when the cardiac tamponade is the presenting feature, and or complicating a lead extraction, or an anomalous approach to lead implantation is present, or we have a great vessels injury or dissections. Passive fixation leads are bulky and have to tinnies, potentially worsening if the leads are pulled transvenously. As we can see here in the chest X-ray, we can see the leads protruding out of the heart in the chest cavity and also in the CT. Now moving to the lead dislodgement or break. The pacemaker lead wire must be in physical contact with the endocardium. The lead dislodgement is the common cause of failure to capture and failure to sense. So we have the Torsens-Ratchet traction effect result in lead dislodgement, the loosely tied suture, allowing the lead wire to move freely with the arm movement. The lead wire is pulled with the arm extension, and it's looped back around the generator when the arm is retained in the natural position. Twiddler syndrome is another cause of lead dislodgement resulting from twisting or rotating the generator within the subcutaneous bucket by rotating the generator. The lead wire can become coiled and dislocated from the heart, as we can see here in this picture. Real syndrome is a variation of Twiddler in which the generator rotated at transverse axis in the bucket. A chest X-ray and ECG is necessary investigation in these cases, and the management, any suspected lead displacement should be assessed by cardiology at first. Depending on the patient, they might need to adjust the lead, replace it, or leave it alone if it's not cause any harm. And it's important to consider a lead displacement or cardiac or heart perforation if there is a QRS morphology changing from the patient from the previous ECG. As we can see here, we can see the lead break and also the coiling. And moving to the pacemaker malfunction, the incidence in symptomatic malfunction is less than 5%. It's present as a failure to base, failure to capture, inappropriate sensing, or dysarrhythmia. If the patient does not sense intrinsic ventricular contraction, it may deliver an impulse inappropriately, which can induce ventricular tachycardia or ventricular fibrillation. In this patient, the investigation starts with the ECG and chest X-ray when considering the malfunction. Moving to the management to this malfunction, patient should undergo pacemaker analysis at first. If the patient is unstable, we have to get a crash card, place a pad on the patient at least 10 centimeters away from the pacemaker bucket, and proceed with the ACLS algorithm. And also we can place a magnet that will convert the pacemaker to asynchronous mode, and sensing will be deactivated, thus preventing the continuity of the reentrant dysarrhythmia. Here's the picture of the magnet ring. Now moving to the pacemaker syndrome, which is loss of AV synchrony produces symptoms related to reflex effect or contraction of the atria against of the closed AV valves. The resulting constellation of the symptoms is known as a pacemaker syndrome. These symptoms are quite variable, but severely affected the patient and may cause them to refuse the pacemaker magnetic testing. Symptoms are relieved immediately by conversion from VVI to double chamber pacing. And the symptoms most commonly include general malaise, easy fatigability, dyspnea or hypnea, cough, dizziness, and atypical chest comfort. And in severe cases, the patient might be present with the sinus symptoms of congestive heart failure. The management mainly is suppurative, and in severe symptoms, the patient may require pacemaker parameter change to restore the atrioventricular synchrony. And this may require changing the pacemaker from single chamber to dual chamber pacing or double ventricular pacing. This is my references. Thank you for you.
Thank you, Dr. Faisal. If you have any comments or questions, please. Okay, by this we conclude our academic activity for today. And last lecture was postponed to next week. Thank you.